And thank you for attending this webinar tonight. My name is Hatem Halabi. I'm the Director of Surgical Oncology at Virginia Hospital Center in Arlington, Virginia. Our talk today, mainly we're going to focus on cytoreductive surgery and heated intraperitoneal chemotherapy. For some reason I lost control on the slides, but now it's working. As far as the outline, we're going to talk about definitions, we're going to talk about indications, what to expect from the surgery itself, outcomes, and alternatives for this treatment. The peritoneum by itself is a membrane that lines the inner surface of the abdominal organs and the abdomen. Peritoneal carcinomatosis, by definition, is the spread of cancer cells into that membrane. As far as indications for cytoreductive surgery, we have what we call primary peritoneal cancers, which are cancers that arise from the peritoneum, and those are called peritoneal mesothelioma or primary peritoneal carcinoma. Both of them are very rare tumors. Secondary peritoneal cancers are more common, and those cancers do arise from the colon, from the stomach, appendix, ovary, uterus, and other organs. Cytoreductive surgery by itself is an extensive surgery, and it does involve resection of all visible tumor that we see on the peritoneal surface. The aim of the surgery is to do a complete cytoreduction, and what we mean by complete cytoreduction is to remove all visible disease. Since we know from our previous studies that complete cytoreduction is essential for a meaningful outcome, which I mean complete cytoreduction is essential to prolong survival. The extent of the resection mainly depends on the intraoperative findings and the primary tumor. In general, we try to avoid bowel resection if feasible. Organs usually resected include the omentum, the spleen is commonly resected, and the gallbladder if they are involved. We always take out all involved peritoneum if feasible. In females, the uterus and the ovaries are also removed. We use multiple modalities to try to destroy any tumors that are in sensitive areas, like on the small bowel or on the blood supply to the small bowel, like what we call electroevaporation. After we do the cytoreductive surgery and after we remove all visible disease, then the heated chemotherapy, or HIPEC, is used. The heated chemotherapy is delivered through a machine that does heat the solution and the chemotherapy, and we have inflow and outflow casters, as shown in the picture, and there is a heat exchanger. Basically, we use the heated chemotherapy for about 90 minutes most of the time, and the reason for doing that is we try to attempt to eradicate any microscopic cells that we cannot see. And the heat itself is shown to be toxic to cancer cells, and it's believed to potentiate the effect of chemotherapy. And this will mainly include the HIPEC component of the treatment. Who is a candidate for cytoreductive surgery and HIPEC? Definitely depends on multiple factors, and we evaluate our patients very carefully for that to make sure that we can tell them that they can benefit from the surgery before exposing them to extensive surgery. So functional status is important. Patients that have good functional status usually do better after the surgery. And the primary tumor is an important factor too, because if the primary tumor is gastric cancer, we know that gastric cancer patients don't do as well, for example, as appendix cancer patients. We are more aggressive with patients with appendix cancer despite their extent of disease, because we know that this is mainly the main modality of treatment that can benefit them. And we are more aggressive with treating appendix cancer patients than, for example, gastric cancer patients with peritoneal carcinomatosis. For me, I do look at response to systemic chemotherapy as an important factor. And that's mainly inferring from other diseases that we treat, because we know if you have a good response to systemic chemotherapy, your outcome after surgery usually is better, because we know that there is a systemic treatment that does work for you. We always look at the extent of the disease, and patients that have more extensive disease inside the peritoneal cavity usually don't do as well as patients that have limited disease. And that mainly applies for colon cancer and gastric cancer primaries. Definitely, the patients have symptoms before the surgery, and not every symptom is a contraindication. But if they have biliary obstruction or obstruction of their ureters, that portends a worse prognosis usually. Definitely, we look at the CAT scan, PET scan, MRI. It depends which modality we use to make sure there's no disease outside the peritoneal cavity. Most of the time, if there's any disease outside the peritoneal cavity, that mainly precludes the patient from having thyroidectomy surgery and heated intraperitoneal chemotherapy. Sometimes we use diagnostic laparoscopy, which is used to assess the extent of the disease. The main reason to use that because we know that the CAT scan, MRI, they do underestimate the amount of disease inside the peritoneal cavity. So we use diagnostic laparoscopy, which is a limited procedure and minimally invasive, to assess the extent of the disease before exposing the patient to a major procedure or operation. So my main workup, usually I try to optimize the preoperative workup as much as possible and to assess what the chances for complete thyroreduction prior to exposing the patient to a thyroidectomy surgery. And mainly we try to minimize complications, and as you're going to see, this surgery is kind of extensive surgery, so we expect complications to happen. But we try to minimize complications by multiple procedures we do and multiple optimize the patient nutritional status before the surgery. As far as surgery itself, it is an extensive surgery. Usually it ranges in about 10 hours on average. Hospital stay is about 7 to 12 days on average. At Virginia Hospital Center, I use epidural catheters for pain control, and usually those work very well for the first 5 days after surgery. Usually ICU stay is about 24 to 48 hours after surgery, and after that you will transfer to a regular floor. We definitely encourage the patient to ambulate as early as possible. Usually once the bowel function returns, we start diet as tolerated. Colostomy or ileostomy sometimes are used. Sometimes they could be permanent. Sometimes they could be temporary. And mainly, most of the patients will start on what we call total parenteral nutrition or TPN on day 1 after surgery, and usually the TPN will be stopped once the patient is tolerating diet well and taking enough calories. It's a team approach, and there's many supporting staff that will work with the patient, including physical therapy, social worker, nursing staff, and coordinators that work with the patient through the process of the surgery. I believe it's a team approach even from the patient standpoint, and motivated patients that do try to push themselves through the process of rehabilitation, they do much better than the patients that don't do that. So I believe it's more like a team approach with the patient as an integral part of that team. You may ask yourself why we should go through these surgeries and why we go through this aggressive surgery in a stage 4 disease. But mainly the outcomes with modern systemic chemotherapy, if we use only modern systemic chemotherapy, for example, in colorectal cancer primaries and peritoneal carcinomatosis, the 5-year survival is about 4%. However, in selected patients, the reported 5-year survival after thyroidectomy surgery and heated intraperitoneal chemotherapy and systemic chemotherapy in colorectal cancer patients has been reported to be about 20 to 5%. So there is marked improvement in overall survival when we use aggressive surgical approach. Alternative therapies include systemic chemotherapy, which is mainly is still considered by many guidelines as a standard of care for treatment of peritoneal carcinomatosis and colon cancer primary, for example. But there is more adoption for the approach of thyroidectomy surgery for patients with limited disease, since the outcomes are usually much better when we proceed with aggressive surgical approach and systemic chemotherapy, more like a multimodality treatment approach. Palliative surgery sometimes is used in certain patients that have symptoms like bowel obstruction. So for me, usually I believe in that approach, and why thyroidectomy surgery and HIPEC? I believe it is mainly, it does improve long-term survival with a relatively good quality of life. And we stress the importance of having good quality of life, since sometimes patients with peritoneal carcinomatosis, if not treated by surgery, they do progress to have bowel obstructions and other problems from the peritoneal carcinomatosis if treated only by systemic chemotherapy. And we have seen that patients that are treated by surgery do better in regard to the quality of life from the surgical perspective and from a treatment perspective, and they do have improved long-term survival. Definitely we have to weigh that against surgical morbidity and complications, and expectation from the treatment. And those expectations are set between a physician and the patients on preoperative workup. That's the end of my presentation, and I'll be happy to take questions.